Well, welcome. And first I want to congratulate the Kennedy Center on the 10th anniversary of this amazing program that they have. And I tell you that because about 300 of my patients have Down syndrome. Most of them are over the age of 40 to 50. And clearly, this is a resource that makes their lives, when they're involved, much easier. And it not only supports them, but it supports families, providers, caregivers, and professionals. So thank you to the Kennedy Center. Thank you for what you do. And this is just the beginning. Those of you that know me, and I see a lot of familiar faces, you know I can go on forever. I'm not going to do that, I promise. I want to leave plenty of time for questions. But let's go back to 1955. Yale School of Medicine and Southbury Training School got together and convened a symposium to discuss the future of adults with Down syndrome. That was pretty progressive back in 1955 when you realized the life expectancy then was about 18 years. If you're born today, and I will tell you this from first-hand experience, the life expectancy with Down syndrome is probably about 68 to 70 years. So there's been tremendous improvements, but with that there come increasing challenges. But this austere group of academics in 1955, the first line of their report, and I have the actual book, I found it in an old library in Southbury Training School, those with Down syndrome are the result of inadequate development or impaired such that they can never adequately adapt to the requirements and demands of society. Well, boy, do you believe that? And we've come a long way, thankfully, for those thoughts and sentiments. So what I'd like to do tonight is to give you a little review as to where we stand, what the future might hold, and what the challenges are, because as you know, there are challenges. There are fiscal challenges, there are challenges in terms of what we can do with the limited resources. The good news is that, for instance, at Yale, we have a whole symposium for the medical students on disabilities, and there is a real interest. You know, just like geriatrics is now kind of the hot field because people realize, well, the population is getting older. I no longer get that glazed look when I talk to medical students or go around and do talks to professionals and other groups where they say, well, why are you talking about that? That no longer happens. So clearly there's been an raised awareness of this very special population. And we have the impetus to make some great changes. So let me just talk about first some of the research that's going on. And I wish I could be more optimistic. Most of the focus of research with those with Down syndrome is now based on earlier identification and diagnosis. There are very few proactive interventional trials, or they are starting to develop. So that means that they are now looking at markers in the cerebrospinal fluid, special proteins, tau markers, that they can take a sample when somebody is 15 to 20, and if it's present, they can say, this looks like you're going to develop Alzheimer's when you get to be 50 or 60. Well, to me, that's kind of a no-brainer, because by the time you hit 50 with Down syndrome now, about 85 to 90% of people are going to have some signs of early, if not more progressive, dementing illness. There's also a wealth of studies on the use of MRI, SPECT scans, and other type of scans to have earlier identification or to identify characteristic patterns of such scans that will make you better able to make the diagnosis. These are all diagnostic studies. The focus of interventional studies are on immunological approaches. I firmly believe, based on my work with those with Down syndrome, that Alzheimer's is not just structural changes. It's not just plaques and tangles. There's a lot more to it than that. And I think the scientific community is now starting to appreciate that and shifting their focus of research not just on, well, what are the anatomical changes, the plaques and tangles, but what are the other conditions that might occur in this particular setting. So clearly, there are research studies on diagnosis, and now, hopefully in the next couple of years, there'll be research studies on interventions. The National Institute on Aging and on Health is putting a lot of money into Down syndrome research, thank God. And even with all the occurrences in terms of funding, most of that funding has been protected, and hopefully moving forward it will be. So there is hope that there'll be better interventional studies. The barriers to such studies are the fact that in the past, these populations were, in a sense, for lack of a better word, abused. And there were studies that were done without following due process. So the pendulum has now swung that it is somewhat of a cumbersome process to get approval to include people in studies with Down syndrome. Years ago, I did a study while I was up at UConn. I was part of a multi-centered study where we were looking at vitamin E to prevent Alzheimer's in people with Down syndrome. Some of you may remember that. Vitamin E was all the rage back then. Everybody was taking vitamin E. You know, it was all over the place. You could get out of vending machines. And we did this large study, but it took me a year and a half to get the IRBs at UConn to approve it, and then the DMR IRB to approve it, because they felt that we were, in a sense, taking advantage of a vulnerable population. So certainly we need safeguards to move forward with such studies, but I do think we have to also realize that the same guidelines and approvals that apply to the general population should apply to the special population as well. By the way, that study did not show any benefit at all. So I just saw a patient today at a clinic, which I still have at Southbury, that was on mega doses of vitamin E, and I said, you know what? That ship has sailed. We shouldn't be using that anymore, because actually it was shown that vitamin E might increase cardiovascular events. So clearly it had a deleterious effect as well. Now all the rage is what? Vitamin D. Vitamin D is all the rage, not just for bone strength, but for falls, for memory, for your heart. Hopefully that will play out in a more positive way. Yeah. But I would want everybody who has somebody that they're involved with Down syndrome to at least have a vitamin D level check. So the research has been slowed by some of these perceived and real barriers, but I do think there is a tremendous interest in doing better research. Now let me make one comment about medications such as Aricept, Namenda, Exelon, because I have, as I mentioned, a whole chunk of patients with Down syndrome who come to me to have their memory assessed. And some of them will be on Aricept, which is, as you know, donepezil. It's a cholinesterase inhibitor. And the first thing I'll do is I'll say, I think I want to stop the medication. And many times I get, well, why would you want to do that? I mean, there's nothing else that works. I'm giving you my best opinion when I tell you that those medications have not been shown in any clinical trials to do anything. They do have increased side effects in the Downs population, and I think that in the long run they do more harm than good. I'll tell you a little secret. I don't want to say it too loudly if there's anybody from a drug company. I don't think in the general population those medications make much difference anyway. You know, you can't watch TV now without seeing a commercial for what? Aricept and Viagra. I mean, those two things. I don't know how they put it together, but see, every time you watch TV, there's a commercial on about that. I think we are overusing these medications, and I would strongly recommend that if you know of somebody with Down syndrome who's on one of these medications, that they be critically reviewed, because I really think there is a paucity of data on the utility of such medications. Now, I do get people say to me, well, what else is there? And sometimes do no harm is better than doing something. And not using a medication might be better than using a medication. So clearly, in terms of research, we are focusing more on immunological therapy. Why is it that, for instance, most of my patients with Down syndrome have sleep apnea, have thyroid problems, have osteoporosis, and have memory problems? There's something that's linking all of them together. If I could figure it out, we'd all be in a better place. What don't they get? The good news is that people with Down syndrome, when they don't get older, do not get coronary artery disease. They don't get high blood pressure, which is, when I do this talk in front of medical professionals, you get the old-time cardiologist, well, what are you talking about? And then I'll say, well, you know what? I don't think I've ever taken care of somebody who has Down syndrome or high blood pressure. If I ask all of you, what percentage of you or how many people have high blood pressure, don't worry, I'm not going to do that. Probably about 30 to 40% would raise their hand. If you were all with Down syndrome, probably nobody would raise their hand. So there's something protective in that 21st chromosome. Is it something lining the great vessels? Is it some other metabolic component that we don't know? Now they get diabetes, and they may get, that cholesterol may be a little high, but they do not get heart disease, and they don't get high blood pressure. And I think that that is because of some protective factor. So there's actually good news. People with Down syndrome, when they get older, do not develop the same types of cancers that the rest of us might. Prostate cancer, colon cancer, and to a lesser extent breast cancer occur much less frequently in this population. Now when you're younger, there might be increased rates of leukemias, but when you get older, solid tumor rates go down. And what does that mean? It doesn't mean I'm telling you shouldn't look for them or screen for it, but they're much less common. So there is some basic immunological process that's going on that has a protective effect and also exposes them to certain conditions. And I think that's what the move is, to focus on that in terms of future research, not just that, oh, well, they have a lot of plaques and tangles, that's why they develop Alzheimer's disease. Now, when people come to see me and they have Down syndrome, it's not always the case that they have Alzheimer's. We do special testing, we do a detailed history and exam, but there's a couple of other conditions that pop up a lot that I want you to be aware of. And those of you that have been with people when they come to see me know that we talk about this all the time. So some of those other comorbid conditions can present all the world like Alzheimer's disease. So if you have sleep apnea, you can't concentrate, you can't focus, your memory starts to slip, and you might have changes in your mood. All of that might be the direct result of the sleep apnea and not the Alzheimer's disease. So one of the first things that we do is we get a detailed history and say, you know what, I think we need a sleep study. And then I always get that look like, you gotta be kidding me. You think that this person is gonna either tolerate a sleep study or much less likely to tolerate one of those mushroom type masks. And I always say, I can never predict. I had a guy last month who basically his parents couldn't manage him anymore. They thought he had advanced dementia. I thought he had sleep apnea. He went for the test. I'm telling the story because I had a good outcome. He went for the test, which they did in his house, which they will now do, instead of having to sit in the hospital artificially. And they determined he had severe sleep apnea. They gave him one of those new nasal prong devices, so it's not like the mushroom on your face, it was a little nasal prong. And they told me within a week, he was back to like he had been when he was 20 years old. Wow. So, I told you so, because they didn't want to study. But having said that, that is one of the typical examples of some of the comorbidities we have to exclude before we just say, oh, well, it's Alzheimer's because you're 45 or 50 with Down syndrome. By the way, I have a patient who's 18 with Down syndrome, who unfortunately I think has Alzheimer's. And that is probably the youngest one. Now, hopefully it'll progress very slowly. He has an extremely supportive family, but they are devastated because physically his life expectancy might be 60 more years, 50 more years, but they are just thinking of the challenges ahead of them. And the other issue is I have a lot of elderly parents who've never been involved with any type of formal services, who could certainly benefit from programs like this, who don't trust anybody, and they'll come to see me and say, okay, you're telling me my son or daughter has a progressive dementia, they're gonna need more help, and you have 88-year-olds who are telling me this, and it rips my heart out because I say, we have to be practical. We have to start to think about other sources of care, because it's not fair to put the burden on other children or siblings, and I'll comment about that as well. So the point is that make sure they don't have sleep apnea, review all the medications. I'm telling you, polypharmacy is rampant. We take a lot of bad medications. All of us do. And certainly this population is maybe more vulnerable to side effects or the like. So, if somebody's taking a sleeping medication or something that has, Benadryl in it, that can look like they have Alzheimer's. I saw a gentleman 2 months ago who was on 4 different antipsychotic medications. And I almost fell on the floor when I saw this. I could not believe it. We started to whittle him away working with psychiatry, and now he's on 2, and his sensorium has cleared to the extent such that nobody else thinks he has Alzheimer's, because it was thought, well, it's progressive and it has to be related to Alzheimer's and not the medication. So I always hear all that time, well, he's been on this medication for so long, it can't be affecting him. Yes, it can. As you get older, these medications hang around a lot longer, and the side effects can be really much more problematic than when you're younger. So think about conditions like sleep apnea, think about medications. Everybody who has Down syndrome should have their thyroid checked at least twice a year, because about 90% of my Down's patients have underactive thyroids. And if you don't check that and don't treat it, you can for all the world look like you can't concentrate, you're falling asleep, you're forgetting things. It's the thyroid. It's not a progressive dementia. So it's very, very important that we look and check for that. We also want to look at what the routine is like. If somebody's starting to have some changes, it might not be appropriate that they go out every day and work in Stop and Shop. And by the way, somebody said to me recently, is that the only job that people with Down syndrome have is working? I said, absolutely not. That is a very Down syndromeism, prejudice to have, to think that that's the only job that people with this condition have. Or they'll say to me, and isn't it always true that people with Down syndrome are very stubborn? If I hear that one time, I said, no, they're not very stubborn. And I have a great story. I had a patient with Down syndrome, very articulate. He came to see me. They thought he had dementia. His thyroid was underactive. We treated it. And while we were doing the assessment, he was there with his parents, and he did have a DDS caseworker who was there. And one of the medical students that was with us sitting in on this event said to him, oh, you must be happy all the time because you have Down syndrome. And he stood up. I was going to kiss him after he did it. He stood up. He looked at the medical student. He said, how dare you have any sense to know what it's like to live your life with Down syndrome? Oh. And that blew me away. Of course, when I heard that, I said, this guy's not demented. This is the medical students we have here. So I'm impressed by that. So, we have to move away from these stereotypes of this population. Because I think that hinders appropriate assessment and treatment when we just are very dismissive about it. So you want to look for reversible and other conditions. And the final condition you want to look for is something that's underdiagnosed, undertreated in the general population, but particularly in this population, and that's depression. Depression is epidemic, I can tell you, amongst our geriatric patients. And the sense is that somehow, if you're depressed, it's your fault. Isn't it interesting how we say if you have cardiovascular disease, or endocrine disease, or vascular disease, but you have depressive illness? Because the term illness means that somehow it's your fault, or that you have some control over it. And nothing could be further from the truth. We know it's caused by biochemical imbalances. And there are some very good, safe, effective treatments that really can work well in our Downs patients. So if somebody appears to have dementia because they're not focusing, they're losing interest, they're having difficulty at their day program, that's another condition that we want to screen for. It's a simple little blood test. You get the results, in half an hour to make sure that's not the case. And then you treat them. You can treat them for depression, and they can do very well. So it's really important that we look for these reversible conditions and don't just say, well, you're 50 with Down syndrome, of course you're going to have Alzheimer's. Now the bad news is most of them will have a component of Alzheimer's. It is very variable though. My oldest Down's patient, you want to guess how old? 81. Wow. 81.
Nice. Yes,
she lives in a nursing home now because she has some mobility issues, but there's nothing wrong with her mind. She has no memory loss whatsoever. And then I told you about the younger kid who has what I think is the beginning of Alzheimer's. Why is that? Why is there such variability? We don't know the answer to that. But just because somebody gets the diagnosis when they're 50, it doesn't mean that by the time they're 55, they're going to be lying in bed forgetting how to eat. Now we know there are situations where they have more progressive functional decline, but it is extremely variable. And we can't let our guard down once the diagnosis is made to assume that everything that occurs to them is a direct result of the Alzheimer's and not one of these other comorbid conditions. You made the point that you couldn't tell if, when there was illness or not, and that is so true. So just because you get the diagnosis, we should not then say, okay, we're not going to be aggressive in looking for other conditions that might affect function in this particular setting. I have never seen more interest in the research community, in the medical community, regarding caring for people with Down syndrome. There have been recently multiple large grants to fund research in this area, and clearly it is something that is now on everybody's radar screen, and that is absolutely great. But we still have a long way to go because we have to move away from this, not only ageism, but disabilityism as it relates to this special population, that, oh, well, there's not much we can do, and whatever happens to them is going to happen anyway. And I think that nothing could be further from the truth. It is a very gratifying population, as you know, I'm preaching to the choir here, to work with, but it can be extremely challenging. Because sometimes you feel like you're the only one who's trying to make a difference. Now I feel like I'm at home here because there are so many people that I know that are really passionate about this. But what we have to do is spread the word. And I used to go around giving talks in hospitals, do grand round lectures, and I could see some people will be falling asleep. What are you talking about? And that's changing now. There is a much more renewed interest in caring for this population, which is extremely gratifying and rewarding. But as I mentioned, it does come with a lot of challenges. The last thing I want to say, and I don't know if I want to have time, but I know people don't want to stay here all night. I can go on all night about this population. The last thing I want to say is we have to take care of each other. And I don't think we do enough of that. We know the fiscal pressures that the state and the system, DDS, is under, and it's not by anybody's fault. We know the stress that can be involved in this population, but we have to also look out for each other. And by coming together as a community such as this, and just reassuring each other that we're here for each other and we're going to help them, I think that is extremely, extremely important. And that's why the Kennedy Center has such a crucial role, because they fulfill that need in terms of alleviating that stress for not only the residents they care for, but for family members, for caregivers, and the like. So we have to advocate, but we also have to care for each other, and I don't think we do that enough. I think we have to say, you're doing a good job. Thank you for taking care of this population. I appreciate what you're doing, and we know you're not doing it for the money, but you're doing it for that inherent gratification that we get from when we do something so important such as this. So I just want to thank you for what you do. Keep doing it. I will keep fighting and being a resource, and together we are making a difference. So we need better research. Funding is coming. We need better focus of research. We need to support institutions such as this. But I'm beginning to see the pendulum swing. Now, 10 years ago, I wasn't as confident, but I am now seeing that we might be coming into the golden age of caring for people with disabilities, which is really important because they're living longer and they contribute so much to what every life is. We don't just do it for them, we do it for ourselves because we get so much from it. All right, so it is 1:45. I want to, anybody have any questions or comments? I don't think I was too dynamic tonight, but it's a little late. Yes?
I've often seen UTIs do crazy things to people. Is that something you've experienced?
Yeah, UTI in any person can cause them to be delirious, which is the acute onset of confusional state. But that is different than the progressive memory changes that we see with Alzheimer's. So if somebody comes to see me and say, my son was fine until a week ago and now he's totally confused, that's not Alzheimer's. That might be the result of an acute medical event such as UTI. So those are the type of things we have to tease out. Or when somebody goes into the hospital, particularly when our Downs patients go into the hospital, you know how vulnerable an environment that is. And it's just a disaster because they're over-medicated, they're isolated, and it's a scary environment. So many times they become delirious. That is not dementia. The other thing I want to say before I forget is there anybody here from the nursing home industry or from a nursing home? Good, and I'll say it. I don't think in general nursing homes are the best place for this population as they get older. Now there are exceptions to that, and there's some great nursing homes that provide good care, but I think many of the staffs in nursing homes are overworked. Yeah. There's a tremendous burden on them. They're taking care of a lot of patients, a lot of residents, and they don't quite get some of the subtleties that are involved in caring for a 65-year-old who has Down syndrome, maybe some memory changes. So once again, we have to better educate and focus on even education in those types of environments because it is different. And and this wasn't your nursing home, so don't take this, but I had somebody recently who was bringing their sister to go live in a nursing home, not dissimilar to your experience, and the admission coordinator said, could you come after hours? Because I really don't want anybody to see the fact that we are talking to you. What? So she called me up. I said, don't go anywhere near that place again. Because they were kind of embarrassed and they didn't want it to be known that we have, quote, people like that here. So we still have a long way to go. But I don't hear that much. But when I do, it kind of was a reality check that we have to do that. All right, yes?
What tips or techniques might you know of for encouraging patients with Down syndrome and Alzheimer's to sleep? At our center, we have them coming in and they haven't slept for 3, 4, 5 days at a time. And then we're like, do we let them sleep during the day? Is that just gonna continue the pattern of them not sleeping at home in the evening? So we really struggle with what can we do to help them relax to sleep? Well, how can we educate their residential staff at home to help them sleep? It's such a battle.
Yeah, so the question is, what do we do about sleep, which is a big issue for a lot of older people anyway, but it seems like in this population. So first of all, you want to make sure that there's no pathology causing the sleep problem. Do they have sleep apnea? Do they have restless leg syndrome, where their feet are jumping around at night that nobody's noticing it? Are they having periods where they're not sleeping or breathing regularly, which could cause them to have disruptive sleep patterns? So the first response shouldn't be, we're going to give them 50 milligrams of trazodone or Seroquel. The first response should be, let me dig a little deeper and make sure that there's nothing that medically that might not be causing this sleep problem. The second thing is to try to modify the environment and the routine. When we go to sleep, our body temperature goes down. So you want to use something like melatonin, which is a natural hormone that lowers your body temperature. The thing with melatonin is you have to take it 2 hours before because it takes a while to kick in. So you can't get an immediate response from melatonin. So that's one other approach. Sometimes a little night light will make all the difference. We actually sleep better when there's a little light than when it's pitch black. You want to make sure there's no extremes in temperature in the room, and you want to stick to a routine. If somebody is in their room watching TV till 3 o'clock in the morning, that's going to be an issue. So you want to try to modify the routine a little bit, but you want to also be flexible such that it meets their particular needs. So number one, don't just jump to a medication. Make sure there's not a medical reason for that, and there are some good common reasons in this population. Try a little melatonin. Try maybe a little nightlight or modifying the routine. But if they come to you the next day and they're tired and they want to sleep, let them sleep. There's no rule that says you only sleep at night, but there is really no good medication. Now, if they become agitated, they get up at night and they want to walk out the front of the building, that's a different story. Then there might be a reason for a medication. Just like wandering. I get asked all the time, what can I give somebody because they get up and wander? Guess what? There's no anti-wandering medication. Right? No such thing. I can give you a medication that can make you fall, that can make you sit in a chair and not move, but there's no anti-wandering medication. Why are they wandering? Do they have to go to the bathroom?
Yeah.
Are they in pain? So somebody who's not sleeping, the first thing I say is keep a sleep log. For a couple of days, tell me what they're doing during the day and what their nighttime pattern is. And many times say, you know what? I think they were in pain because they have arthritis and they were lying on one side. So we gave them some Tylenol and now they're sleeping. Or maybe they had to get up and go to the bathroom, but they were a little confused, so we now have them on a schedule where we bring them into the bathroom and then they can sleep better. So there's a lot more to it than just the knee-jerk response of, here's your trazodone or your Seroquel and call me in 2 weeks. Yes?
So, I'm a psychiatric social worker, so I'm somewhat familiar with psychotropic medications. Is there any evidence with other medications, not necessarily psychotropic medications, which, by the way, I'm also the parent of a little boy with Downs, who's 20 years old, who also receives services here at the Kennedy Center. Is there any evidence of other medications that may appear to indicate that they affect their functioning, that in essence may almost mimic like the Alzheimer's?
Yes, I mean, there are certain medications that when you take them, even in the short term, can affect your cognition, your memory, your ability to respond to the environment. So apart from the antipsychotics, which you're familiar with, benzodiazepines, Valium, Xanax, those types of medications can be problematic. There are medications, for instance, I told you that people with Down syndrome don't usually have high blood pressure. In fact, their blood pressures are very low. And sometimes they get put on other medications for urinary retention, ditropin and those medications that lower the blood pressure even more. So maybe they're hypotensive, or when they stand up they get dizzy and then they start to have difficulty processing things because of that. So there's other medications that we know that can cause symptoms that look for all the world like Alzheimer's. But that's why a crucial review of all of the medications is extremely important in this population. Yes?
Before
before the baby is born, is there any research for that extra chromosome that maybe that they could maybe string it out or?
So that's an interesting question. There's been a couple of trials, mostly in Europe, where they not only do, amniocentesis to do early identification, but then they are trying some vitamin therapies to maybe blunt the progression or the manifestation of how the gene affects things. They have all been very preliminary, and there's been no strong evidence that they work. The other thing that people do talk about is, well, isn't it common, especially now where prenatal testing, genetic testing, and amniocentesis, is the birth rate for people born with Down syndrome going down because people are just not going to have them? There is no evidence that that's the case. There is no evidence. So clearly, that type of research is real cutting edge. Genetic interventions, nobody's really done that. It's more using supplemental vitamins in the mom to see if that can make a difference. But I don't think there's been any conclusive evidence that it really works. Another interesting anecdote, and I might have said this years ago, is if you're pregnant over the age of 35, which a lot of women are now waiting to have children, your chances of having a child with Down syndrome goes up. It might not go up as much as we previously thought, but the other interesting anecdotal converse of that is there have been a couple of studies which have said that if you have a child with Down syndrome and you are younger than 35, you yourself might be at increased risk for developing Alzheimer's later on, which is fascinating. And I don't know what that means, except we know the #1 risk factor for Alzheimer's is getting old. Our patient was 99. And the daughter said, "Oh, I'm concerned that her memory is slipping, and I'm thinking of bringing her to the gym." She's 99. I don't know if I bring her to the gym to try to clear up her memory. So it's a completely different landscape. Yes.
A lot of the people here are professionals. I'm not. I'm a grandmother raising my granddaughter with Downs. I was wondering at what point, or is there something you have to look for first before you take her for testing on the Alzheimer's?
Yeah, so that's a great question. As I said, I do have a few younger patients. My sense is if there starts to be any change in routine, if you're concerned that maybe they're not functioning at the level that they were at any age, it's always a good idea to establish a baseline so that you can track changes over time, or maybe be reassured that there's nothing wrong. So it's never too early, but at some point you might want to say, let me just get some baseline memory assessment and testing and make sure that, so we have a good solid baseline so that maybe down the road when things do occur, we have a better point of comparison. Yes?
So I am the caregiver and a social worker, but my uncle is 61 years old with Down syndrome. And we actually brought him to you a few years ago because the nursing home where he was living convinced us he had Alzheimer's and had all the drugs in the world on him. Went to you, cleared up some stuff, took things away, he did better, thank you. But now that he's 61, we are seeing some signs he's slowly starting to forget a little bit and find motor skills. Any activities you can suggest that we try doing with him? I know my older population I work with, we have brain teasers, and anything in particular we can
Yeah,
do
that's a
with
great
him?
question. Keeping people engaged is very important. However, the ability to do that with this special population is not the same.
Yeah.
So, doing these brain teasers, word search, all these other activities. Find the activity that he was most happy doing, and it might mean, listening to certain types of music, listening to certain television shows, or even looking at newspapers, coloring, drawing, and make sure at least for a period in each day he gets an opportunity to do that uninterrupted.
Okay.
And that's been shown to be most helpful. If you focus on what they used to like to do, instead of saying, okay, we're going to do brain aerobics, and I want you to repeat these 8 numbers, that's not going to work in that population. The other thing I always, and correct me if I'm wrong, what is the most popular entertainer or music amongst those with Down syndrome? Anybody want to guess? I haven't done research on this, but I can tell you. Elvis. Elvis.
Or the
Some of
50s.
them know the words, they know the moves, and they love coffee. had a group home manager say to me, well, we limit the coffee, and she's very anxious, she's screaming, why are we limiting the coffee? You know, we give her coffee. So, remember that. Elvis and coffee.
And not decaf coffee, regular
Not
coffee.
regular coffee. Coffee. And I'll tell you a little secret, I used to work as a waiter in a restaurant, I didn't last very because I just, when they say you're getting decaf, half the time you're not. So don't hold your hat on that. All right, well, it is almost 7 o'clock. Let me just end with one of my favorite stories. A woman who was 50 with Down syndrome, and she came to see me, and I introduced myself to her and her DDS caseworker. And I said, oh, so you're here, you know, I want to do a little assessment. I know you have Down syndrome. She said, stop. She goes, I don't like to be referred to as having Down syndrome. Why can't we say up syndrome? I thought about it and said, you know what? Why can't we? Now, it was named after the guy who first kind of described the condition, but even the name has a somewhat negative connotation. So from now on, I don't use that term unless I have to, when I say, let's use up syndrome. Okay. Thank you again for what you do. And trust me, things are getting better, so keep up the good work. All right, thank you.